Good afternoon, everyone, and thank you for joining us today. I'm Erin Ticehurst. I am a Associate Director of Professional Practice within Penn Medicine, and I'm pleased to have four speakers with a lot of great content to share with you today. We'll kick it off by going through a few housekeeping items for today's webinar. The first is that we do want you to keep an eye on your microphone so that it remains muted for the duration of today's presentation. You'll find your mute button in the lower left-hand corner of your screen. If you do find at any point that you're having a question for the speaker, please go ahead and submit that question using the chat functionality at the bottom of your screen. We'll save the questions for the end. And then if you do experience any technical difficulties during the webinar, try logging out and then logging back in or taking a look at your internet connection. And if you do continue to have problems, please enter a note in the chat so that we can follow up on that with you. Last but not least, today's session is eligible for CE credit, so all attendees will receive instructions via email on how to obtain credit at the conclusion of the webinar. So now I have the pleasure of introducing our speakers, beginning with Dr. Bethany Lane. She is one of the solid organ transplant clinical pharmacy specialists at the University of Maryland Medical Center, where she covers both inpatient and outpatient services for liver, heart, kidney, and lung transplant. She completed her PGY1 pharmacy residency at the Cleveland Clinic and her PGY2 at Ochsner Medical Center. We also have Dr. Helen Swice joining us today. She is one of the solid organ transplant clinical pharmacist specialists at the University Health San Antonio, where she covers both inpatient as well as outpatient services for liver, lung, kidney, and other transplants. She completed her PGY1 and PGY2 pharmacy residencies at University Health San Antonio, and she stayed on board after residency to further expand their outpatient transplant pharmacy services. She is now serving a 2-year term on the AST Transplant Pharmacy Community Practice Executive Committee, and she recently was inducted as a fellow of the American Society of Transplantation. Dr. Olivia Huber will be speaking today. She is currently a heart transplant pharmacist at the University of Wisconsin Hospital and Clinics, and she's practicing primarily in the outpatient setting. She completed her PGY1 at Henry Ford Hospital and her PGY2 in solid organ transplant at Tampa General Hospital. Then she joined the UW Health team and established heart transplant pharmacy services. She is an active member of both AST and ACCP who are supporting today's webinar, and she's currently serving as the vice chair of the ACCP Transplant PRN Social Media Committee. I'd also like to introduce Dr. Yen Pham. She completed her PGY1 and PGY2 in ambulatory care at the University of North New Mexico Hospital. She stayed on after residency as the CKD and solid organ transplant pharmacist clinician, where she covers both inpatient and outpatient for kidney transplant. She also has her own cardiovascular risk reduction clinic for CKD and post-kidney transplant patients. And now I'll give the floor to Dr. Lane, who is our first speaker.
Thank you so much for that introduction. Following today's presentation, we will review the pathophysiology of the metabolic complications following solid organ transplant, as well as to describe appropriate therapies and preventative strategies to decrease cardiovascular risk. Over the past decade, we've seen a continued increase in the number of transplants performed each year, with over 46,000 transplants being completed in 2023. This record increase is due in part to improvements in short-term patient and allograft survival, largely due to improvements in immunosuppression and decreased risk of rejection. However, long-term patient survival has largely remained stagnant, with cardiovascular disease due to metabolic complications being the most common cause of death with a functioning graft. While our patients often have traditional risk factors associated with increased risk of cardiovascular disease, studies have shown that control of these factors within the transplant population is often poor. A study by Kasiski and colleagues found only 56% of kidney transplant recipients achieved a systolic blood pressure less than 140 milligrams of mercury at 1 year post-transplant. In addition to these traditional risk factors, transplant introduces many non-traditional risk factors, including chronic inflammation, oxidative stress, endothelial dysfunction, and chronic volume overload. Use of immunosuppression in and of itself also plays a role in increasing cardiovascular risk, as each of our classes of medications can cause metabolic complications, including calcineurin inhibitors being associated with hypertension, hyperlipidemia, and hyperglycemia. Our corticosteroids, though we try to minimize our use when we can, are associated with hypertension and hyperglycemia, and our mTOR inhibitors being associated with hyperlipidemia. Highlighting the major metabolic complications that contribute to this increased cardiovascular disease risk, starting first with hypertension. The prevalence of hypertension post-transplant does vary by organ type across the transplant population, with the majority of kidney and heart transplant patients having post-transplant hypertension requiring treatment with medication. Hypertension has been independently associated with graft failure, death-censored graft failure, and death after adjusting for kidney function, acute rejection, and other transplant variables in our kidney transplant population. While traditional risk factors such as pre-transplant hypertension, obesity, tobacco use, and salt intake can play a role, transplant patients are also impacted by several donor factors, including pre-existing donor hypertension, older donor age, and poor allograft quality. In kidney transplant recipients, a disparity between donor and recipient size can lead to a relative underdosing of nephrons and subsequent maladaptive hyperfiltration, glomerular hypertrophy, and intraglomerular hypertension. Multiple mechanisms play a role in CNI-induced hypertension, including both systemic and renal vasoconstriction. Renal vasoconstriction is caused by the production of endothelin in larger preglomerular arteries, where it acts via endothelin A receptors. Additionally, CNIs can increase the sympathetic nervous system by enhancing the production of endothelin and angiotensin, as well as decreased production of nitric oxide, leading to decreased spontaneous relaxation and decreased vasodilation. Lastly, CNIs act directly to the sodium chloride transporter on the nephron that's enhanced by WNK and SPAK kinase to cause sodium retention, leading to hypertension. When thinking of our treatment, patients should employ a non-pharmacologic intervention, including dietary sodium restriction, exercise, and weight management. Initial pharmacotherapy typically includes the use of dihydropyridine calcium channel blockers, such as nifedipine or amlodipine. In a Cochrane review, dihydropyridine calcium channel blockers were associated with a significant decrease in renal allograft loss and an improvement in glomerular filtration rate. Alternatively, nonspecific beta blockers, such as carvedilol, may be used. Initially, during the first 3 to 6 months post-transplant, agents such as ACE inhibitors or ARBs are often avoided due to the risk of hyperkalemia, anemia, and the reduction in glomerular filtration rate associated with this class of medications. However, long-term, this class of medications may prove to be beneficial due to their mechanism of action to reduce proteinuria and structural kidney changes. Moving on to another complication that may occur pre-transplant, it's often an indication for our kidney transplant recipients, diabetes. Prevalence in the transplant population varies greatly by organ, and this is due in part to a prior lack of a standard definition, presence of both modifiable and non-modifiable risk factors, duration of follow-up, the type of organ transplant, and the primary diagnostic indication for transplant. While there are many non-modifiable and modifiable risk factors our transplant patients may meet, there are also many transplant-specific risk factors, including the use of immunosuppression, specifically corticosteroids that may induce or worsen pre-existing insulin resistance, presence of a persistent inflammatory state, including both acute and chronic systemic inflammation. Post-transplant diabetes involves both increased insulin resistance and beta cell dysfunction. Calcineurin inhibitors result in increased insulin receptor endocytosis, reduced beta cell mass, leading to beta cell dysfunction and increased islet cell apoptosis. Corticosteroids contribute to insulin resistance, and mTOR inhibitors also act via decreased beta cell proliferation and directly impacts to provide negative feedback for multiple protein kinase-dependent phosphorylation among the insulin signaling cascade. When thinking of management post-transplant, it's often broken down into the immediate post-operative phase or index admission and short-term management, often the first 1 to 2 months post-transplant. During this phase, patients are often managed with insulin therapy via a basal bolus regimen. And it's really this longer-term therapy where new questions have arisen into the management and how to minimize the risk of cardiovascular disease post-transplant. The most recent ADA guidelines now provide recommendations specific to those with an increased cardiovascular risk, including those who have a history of ASCVD or who are at high risk of ASCVD, those who have heart failure, and those who have or are at risk of developing CKD. Remembering our risk factors for cardiovascular disease, our transplant patients would fall into these high-risk categories and warrant use of these novel therapies, such as the GLP-1 receptor agonists and SGLT2 inhibitors. With the most recent ADA guidelines, GLP-1 agonists and SGLT2 inhibitors have moved to be first-line therapy, in part due to the cardiovascular and renal protective effects seen in clinical trials in the general population. However, limited literature is available in our transplant population, and these patients may be at an increased risk for side effects, including hypovolemia-induced acute kidney injury. Reviewing the available literature for GLP-1 and SGLT2 inhibitors, a systematic review by Krisanapan and colleagues included 9 cohort studies of kidney transplant recipients. It was found that dulaglutide was the most commonly prescribed GLP-1 agonist, followed by liraglutide. The time to initiation was reported in 2 studies and occurred at a mean time of 7.7 months and a median of 24 months. In terms of glycemic control, a significant difference of minus 0.85%, and in a subgroup analysis, this significant difference was only seen with short-term treatment, meaning less than 12 months, whereas no significant difference was seen with long-term treatment. In terms of graft function, no significant changes in GFR from baseline were observed during treatment. And additionally, a significant reduction in urine protein to creatinine ratio was observed with GLP-1 therapy. In terms of weight management, significant reductions in weight and BMI were observed in both the short and long-term period. And finally, evaluating the impact of GLP-1 agonist therapy on tacrolimus trough levels, the authors found no significant impact on trough levels when compared to baseline. Evaluating our literature for SGLT2 inhibitors, a review by Ramakrishnan and colleagues identified 9 studies in the kidney transplant population and found empagliflozin to be the most commonly prescribed SGLT2 inhibitor, followed by dapagliflozin and canagliflozin. Median time from transplant to initiation was about 3 years post-transplant. In terms of glycemic control, hemoglobin A1C improved significantly, ranging from 0.2 to 1%, with a more robust response or impact on glycemic control seen in those with a higher A1C and eGFR at time of initiation. In terms of graft function, baseline eGFR was about 67 mLs per minute per 1.73 meters squared and was preserved in most studies over a period of 6 to 12 months. One study by Lim and colleagues did see a 10% dip in eGFR in about 16% of patients, though eGFR did recover and stabilize from this. In terms of other outcomes, Ramakrishnan and colleagues found a weight decrease of approximately 2 kilograms, as well as a clinically significant reduction in blood pressure. And no statistically significant differences were seen in tacrolimus trough levels after SGLT2 inhibitor initiation. Both reviews evaluating GLP-1 and SGLT2 inhibitors suggest these classes of medications are both safe and effective to use in our post-transplant population. Reviewing the last metabolic complication contributing to cardiovascular disease, dyslipidemia. Similar to our previous complications, dyslipidemia prevalence post-transplant varies greatly by organ type, with its highest prevalence occurring in our heart transplant recipients. Dyslipidemia can be broken down into 2 categories, hypercholesterolemia and hypertriglyceridemia, with different risk factors for each. Of importance, use of immunosuppression can increase the risk of both hypercholesterolemia and hypertriglyceridemia. Reviewing how each class of medications can contribute to dyslipidemia, corticosteroids can increase cholesterol and serum triglyceride levels in a dose-dependent manner, as well as contribute to insulin resistance. Calcineurin inhibitors result in increased hepatic enzyme activity and increased production of low-density lipoprotein, as well as decreased clearance by decreasing the activity of lipoprotein lipase. Lastly, mTOR inhibitors have been known to cause increases in LDL and show similar effects as our calcium urine inhibitors. Currently, there are no clear transplant guidelines specific to the transplant population, and further studies are needed to establish lipid targets, especially to determine if transplant populations will have the same benefits from lipid-lowering therapy in achieving very low LDL levels as the non-transplant population. It has been well established, though, that transplant patients should be considered high risk for ASCVD, with the National Kidney Foundation Disease Quality Outcome Guidelines considering renal transplant as coronary artery disease equivalent risk, and the ISHLT guidelines recommending the initiation of a statin post-transplant regardless of cholesterol level. Two major trials in our transplant population include the ALERT study and a study by Kobayashi and colleagues. The ALERT study evaluated fluvastatin versus placebo in kidney transplant recipients and found fluvastatin lowered LDL significantly, however, was associated with a non-significant decrease in their primary outcome of non-fatal MI, CAD interventions, or cardiac death. Kobayashi, I am struggling with that name, so sorry, evaluated pravastatin in heart transplant recipients versus control and found that pravastatin patients had lower cholesterol levels as well as less frequent cardiac rejection and better one-year survival. Statin therapies have remained first-line. When choosing a statin, it's important to remember drug interactions may have a maximum dose or not recommended. Maximize the dose of statin therapy. Alternative agents may be considered, including cholesterol absorption inhibitors or bile acid binding resins. Though it's important to remember with bile acid binding resins, these medications result in a significant decrease in mycophenolate absorption, potentially resulting in reduced immunosuppression levels. To summarize the three main metabolic complications leading to increased cardiovascular risk, for hypertension, blood pressure should be reduced to a goal of less than 130/80, with first-line agents being dihydropyridine calcium channel blockers. For diabetes, A1C should be reduced to less than 7%, with long-term management utilizing our novel anti-diabetic agents. And for dyslipidemia, though not clearly established, LDL should be reduced to less than 100 milligrams per deciliter, utilizing our statin agents as first-line therapy. And with this, I'd like to turn it over to our next speaker.
All right. Hello, everyone. My name is Helen Swice, and my portion of the presentation is really going to be focusing on interventions we can make as pharmacists to improve cardiovascular health in our transplant patients when it comes to diabetes management. Which is really the primary objective of today's presentation, but we'll also be able to describe appropriate glycemic agents to reduce cardiovascular risk, as well as understand their mechanism of cardiovascular risk reduction. So post-transplant diabetes, or PTDM, is a common complication after transplant and is associated with many negative outcomes, including increased risk of infection, decreased allograft and patient survival, as well as death from cardiovascular complications, which is why it's so important to not only optimize our diabetes regimens from a glycemic standpoint, but really from a cardiovascular standpoint as well. We now have many non-insulin therapy options for management of diabetes after transplant, listed here, with some of our more novel agents being our GLP-1s and SGLT2 inhibitors. And these have really changed the trajectory for diabetes management. For the purpose of this presentation, I will be focusing on the first two agents or classes, since these are the ones that have some cardiovascular benefit, and really a little bit about how we have incorporated these agents in our diabetes management at University Health and in our pharmacy diabetes clinic. So I think that as time has progressed, so has really our approach to managing diabetes. So previously, we just wanted to get their blood sugar under control, But with more diabetic agent options, we're really able to optimize their diabetes management even by personalizing their therapy options based on whether they have cardiovascular disease, kidney disease, or obesity. And again, for the purpose of today's presentation, we'll really just be honing in on the management of diabetes while also optimizing therapy to really reduce that cardiovascular risk. So before I jump into our treatment strategies, I do want to just take a moment to give some background on how our transplant pharmacy diabetes clinic works. So when our transplant nephrologists identify patients with either uncontrolled diabetes or patients who still remain on insulin and who would potentially benefit from non-insulin therapies, providers can actually refer those patients to the transplant pharmacist diabetes clinic. So after the provider has verbalized that they need the referral, the pharmacist will then see the patient alongside the provider just for that first visit. And then the pharmacist tags that patient under a pharmacy diabetes protocol within Epic. Independent follow-ups are really typically determined up to that clinical discretion of the pharmacist. And then once a patient has really established care with endocrinology, that's when they're discharged from the pharmacy diabetes clinic. So really this clinic is kind of serving as a bridge to endocrinology care. Now, when we created this clinic, we really took this as an opportunity to completely revamp our diabetes protocols to be able to personalize diabetes management based on these comorbidities, and really finding ways to incorporate agents with more than just glycemic benefits into our management. So how do we approach diabetes management in our kidney transplant recipients? We split it up based on the time post-transplant. So if we look on the left-hand side, you'll see that this focuses on patients that are in the first 1 to 3 months post-kidney transplant. So our first-line options are typically GLP-1s, dual GLP-1 GIP, or tirzepatide, or metformin. And so BMI is really the determining factor for this. So if BMI is greater than 22, we'll initiate a GLP-1. It will offer that weight loss benefit in addition to those glycemic benefits. However, if BMI is greater than 35, we'll actually try to get tirzepatide on board with these patients, since we typically see a much greater level of weight loss with tirzepatide compared to just the GLP-1 alone. And then if they have a lower BMI, less than 22, we'll usually start with metformin, since a lot of those patients, we're actually trying to help them maintain weight rather than lose weight. So I'll be going each of the cardiovascular benefits of these agents in just a few slides. But usually if they have ASC risk or significant cardiac history, we really try to get them on a GLP-1 containing agent at that time. Once a patient's urethral stent is removed, that's when we can potentially consider an SGLT2 inhibitor. However, we want to make sure that their serum creatinine has been stable as well as their blood pressure. If for any reason patients have contraindications for any of these medications, or they still require further glycemic management, they can still utilize one of these alternative therapies listed here. Now, when patients are greater than 3 months, so that's the right side of this protocol, our first line options are usually either GLP-1s, the GLP-1 or SGLT2 inhibitors. And at that point is when we're really deferring more to the general ADA guidelines. So we're taking things like heart failure, CKD, and weight loss into consideration. One thing that's definitely slightly unique and potentially controversial is this box that says to consider switching from metformin to an SGLT2 inhibitor if they're currently on metformin. And this is really to try and ensure that we're optimizing therapies for both renal and cardiovascular benefits. A lot of times we can't start an SGLT2 inhibitor right away, potentially due to their renal function or if their stent is placed. And we want to make sure providers really don't forget that we still have this option of an SGLT2 inhibitor in patients once they're actually able to meet criteria to start it. So this update in our protocol really had a push for the GLP-1s and the SGLT2 inhibitors. Whereas previously, our protocol primarily included more historic agents like the TZDs, insulin, sulfonylureas. So why this big push for these agents? That's what we're going to jump into now. First is the SGLT2 inhibitors, which I've listed out here along with its dosing. We typically can expect about a 1 to 1.5% reduction in A1C. And then the most common adverse effects that we typically see are going to be hypotension or dehydration, as well as concern for increased genital mycotic infections. Now, these agents work by having an effect on kidneys, liver, and the pancreas. So its natriuretic and diuretic effects really contribute to that reduction in blood pressure and plasma volume. We also see effects on the blood vessels, which results in that vasodilation, increased RAS activity, as well as endothelial. All of these effects combined ultimately result in that reduction in preload and afterload, decreased hypertrophy, as well as oxygen demand, which is really why these agents are preferred in our heart failure patients, and have also demonstrated such a significant impact on cardiovascular health in the trials. So when we look at those trials evaluating the SGLT2 inhibitor safety and efficacy, I've included just a few key studies here, including the DECLARE-TIMI, DAPA-HF, as well as the EMPEROR studies, which really showed significant reductions in blood pressure, as well as composite cardiovascular death or hospitalization. Now, when we look at where the SGLT2 inhibitors are recommended in the general population, we see that it's recommended as a first-line agent for diabetic patients with heart failure, given that heart failure benefit. When it comes to patients with high ASCVD risk, an SGLT2 inhibitor or a GLP-1 can be considered, as well as with patients who meet high-risk criteria, which is defined as greater than or equal to 55 years of age, with 2 or more of the additional risk factors listed here. Now that's in the general population. When we look at this in transplant patients, we do have the consensus recommendations on PTDM, and this was actually just updated earlier this year in February. And so the general recommendation includes either metformin, SGLT2 inhibitors, GLP-1s, or DPP inhibitors. However, when we personalize it to comorbidities, the SGLT2 inhibitors are recommended in the setting of heart failure, as well as CKD. And then the GLP-1s are recommended for consideration in the setting of established ASCVD. Which really segues into the next agent that we'll talk about, which is the GLP-1s, which are listed here. We can typically anticipate a reduction in A1C of about 1 to 2%. In addition to its glucose lowering effects, it also does slow gastric emptying, which is why we end up seeing that weight loss reduction with these agents, as well as the adverse effects that we can expect with the GLP-1s, which are typically going to be GI related. The GLP-1s do have many direct and indirect effects mechanistically. It does increase insulin secretion from the pancreas to help with blood glucose control, but it also provides some level of cardioprotection. And it does so by promoting myocardial glucose uptake, reduces oxidative stress, as well as inhibits cardiomyocyte apoptosis. So these mechanisms collectively had that cardioprotective effect, heart function, as well as with helping with preventing any adverse cardiac remodeling. So this chart here provides a summary of the cardiovascular trials for the GLP-1s, but the 2 that I really wanted to focus in on are the SUSTAIN-6 and the PIONEER-6. So the SUSTAIN-6 trial, which looked at patients with established cardiovascular disease or CKD, showed that semaglutide was non-inferior to placebo for primary composite outcomes of the first occurrence of 3-point MACE. And then at the PIONEER-6 trial, It assessed cardiovascular safety of semaglutide in people with type 2 diabetes with cardiovascular disease. And again, it showed non-inferiority when compared to placebo for that primary composite outcome of 3-point MACE. Again, when it comes to patients with high ASCVD, the ADA guidelines recommend either the SGLT2 inhibitor or GLP-1, as well as in those patients with the high risk criteria. So the greater than 55 years old with 2 or more of those listed high risk criteria. When we look at the consensus recommendations for PM, GLP-1s are recommended in the setting of obesity and/or ASCVD. And this is really due to its benefits in the composite cardiovascular outcomes that we've seen in the general population. So for time purposes of today's presentation, I really only focused in on the novel agents of the SGLT2 inhibitors and the GLP-1 receptor agonists. I do want to at least mention other agent classes. Specifically, I wanted to mention these non-insulin agents highlighted here that we probably more historically used in our transplant patients. So with metformin, we haven't forgotten about good old metformin. And when we look at the cardiovascular effects, it can have that potential benefit on MACE outcomes with really no impact on heart failure. However, the data just isn't as strong as the more novel agents that we're now using. With DPP-4 inhibitors and the sulfonylureas, it is cardiovascular neutral. And when it comes to cardiovascular neutral when it comes to MACE and heart failure. And then lastly, our TZDs have that increased risk in heart failure patients, stage 3 and 4. But I will say we just completely avoid it in our heart failure patients at our own center. So I think you could spend a whole hour-long webinar talking about this topic specifically in diabetes. But I do hope that this presentation really just gives you a glimpse into how we approach optimizing diabetes therapies to help reduce cardiovascular risk and kind of the why of what we're doing at University Health. Taking questions at the end, so I will go ahead and hand it off to the next presenter.
Okay. My name is Olivia. I'm going to be talking about dyslipidemia management and solid organ transplant here today. So firstly, when I came to my position here at UW, it was a new heart transplant pharmacist position. So my first step was establishing pharmacist workflows. Previously, for heart transplant clinic, the clinic staff would reach out to the inpatient heart failure or cardiac surgery pharmacist or the outpatient abdominal transplant pharmacist via in-basket message and Epic as needed, but they didn't have a necessarily go-to pharmacist. And we do have heart transplant clinic often Monday through Friday. So when I started here, I implemented patient review prior to clinic visits and documentation in a quote unquote living note in the EMR with recommendations for the provider as well as an overview of the patient. This is documented in a care coordination note under the problem list in Epic, which is something I picked up during my PGY2. So shout out to Bailey Wise for that workflow. Then we looked at our hyperlipidemia screening. So when I joined the institution, our state was getting a fasting lipid panel baseline pre-transplant, then around yearly at the patient's annual visits, and then as needed at the discretion of the provider or the nurse coordinator. Currently, we still get a baseline fasting lipid panel pre-transplant and still check yearly at the annual visit, but we do try to check in 3 months after any change in lipid therapy and get a baseline fasting lipid panel when starting an mTOR inhibitor, and then 3 months after starting an mTOR inhibitor to track those lipid values.
So why is hyperlipidemia intervention relevant in heart transplant specifically? Different metabolic factors, including diabetes, hyperlipidemia, and hypertension, can contribute to the risk of cardiac allograft vasculopathy in our heart transplant recipients. And dyslipidemia and heart transplant can be exacerbated by mTOR inhibitors, although the effects from this haven't been shown to increase the risk of CAV. As we know, mTOR inhibitors decrease the risk of CAV. And statin therapy associated with decreased incidence of CAV, as Bethany mentioned, the original study in 1995 by Kabashgawa and colleagues, as well as their 10-year follow-up study and a mountain of other evidence support statin use for all heart transplant recipients. And even in statin intolerant patients, we know that hyperlipidemia management still decreases the risk of CAV. I wanted to briefly touch on again the effect of our immunosuppressive agents on lipids, pointing out, I think a lot of us remember that mTOR inhibitors have a pronounced effect on triglycerides, but they also have a pronounced effect on LDL as well as total cholesterol, along with our corticosteroids and our calcineurin inhibitors. So after I joined the institution, we also created a pharmacist and nurse coordinator delegation protocol, which encompasses more than what is included on this slide, including immunosuppressive therapy management. But I wanted to highlight our statin and PCSK9 inhibitor sections. So we start all of our patients on 20 milligrams of pravastatin after transplant with a goal to titrate to 40 milligrams. And we are able to order CK, LFTs, and fasting lipid panels. Our alternative agent when patients need a high-intensity statin is rosuvastatin. Our primary antifungal agent at UW is posaconazole, so we avoid atorvastatin due to the contraindication of giving atorvastatin and posaconazole together. So we also utilize rosuvastatin as our high-intensity statin agent. For statin-intolerant patients who need lipid management or patients who are on a maximally tolerated statin and still need lipid management, we also have a delegation for PCSK9 inhibitors, both evolocumab and alirocumab. And our LDL goals are a little bit different. So in most heart transplant recipients, we are targeting that less than 100 milligrams per deciliter goal. But our institution decided for patients with a history of ischemic cardiomyopathy prior to transplant, type 2 diabetes, stroke, or peripheral vascular disease, we would target an LDL goal less than 70 milligrams per deciliter. Then I wanted to briefly go through what is in our anti-hyperlipidemic arsenal. So we have statin therapy, ezetimibe or Zetia, our fish oil products, PCSK9 inhibitors, and then some newer agents, bempedoic acid and inclisiran, which I won't specifically be talking about today. That's a little bit of a newer agent. It's an anti-lipemic small interfering ribonucleic acid agent. But I just wanted to point out it can't be used with PCSK9 inhibitors together because there's not data supporting additional LDL lowering. So I think there would be a very small population of patients who maybe can't tolerate a PCSK9 inhibitor for any reason who might be on this agent. Starting off with statins, these are the most studied and efficacious pharmacotherapeutic class in solid organ transplant recipients as a whole, and should be first line for dyslipidemia unless contraindications exist, as Bethany mentioned. There are some recommended dosing limits with cyclosporin, so atorvastatin being capped at 10 milligrams, fluvastatin at 40 milligrams, pravastatin at 40 milligrams, and rosuvastatin at 5 milligrams. Technically, this should be the same for tacrolimus and our mTOR inhibitors, but in practice, these interactions have been shown to be less. And in studies in mTOR inhibitors, there were more CPK elevations in patients who were switched from cyclosporin to an mTOR inhibitor, but no subsequent increased adverse events occurred. Then we have ezetimibe. This lowers LDL-C by about 15 to 20% with or without statin therapy in non-solid organ transplant recipients. And when added to statin therapy post-MI, patients with a mean LDL-C of 70 milligrams per deciliter produce a 6% relative risk reduction in recurrent ASCVD events. There is an interaction with cyclosporin, so consider a maximum daily dose of 5 milligrams, but stick with 10 for other immunosuppression. And studies in solid organ transplant show an effective LDL lowering and greater attainment of goals without any effect on immunosuppressive pharmacokinetics. I wanted to point this out. There seems to be some sort of misinformation, at least in my program, that a lot of our providers think that ezetimibe is a great agent for hypertriglyceridemia management. So that's a great intervention that a pharmacist can make to point out that it's more so LDL lowering. And if we need lowering of triglycerides, we should pick an alternative agent. Then we have the fibrates, fenofibrate and gemfibrozil. These have effective lipid lowering effects, but do have some safety concerns. Gemfibrozil and fenofibrate have been shown to reduce plasma concentrations of cyclo by 18% to 27% and everolimus by about 58%. There is an increased risk of muscle toxicity when used in combination with statin and cyclosporin, and can exacerbate gastrointestinal issues and have an additive effect on creatinine with tacrolimus. The cardiovascular benefit is only seen with triglycerides greater than 200 and HDL less than 35. And generally in our program, we use these very cautiously or flat out avoid fibrate use in our patients, but we would generally prefer gemfibrozil over fenofibrate. Then we have our bile acid sequestrants, cholestyramine and cholesevelam. These can bind mycophenolate and decrease total drug exposure by 40%. And it doesn't really matter how long you separate the medications from each other, you'll still see that effect. Cholesevelam also binds cyclosporin and decreases plasma levels by 44%. This medication also has to be separated 2 hours before or 4 hours after all other medications and have adverse effects of GI intolerance and triglyceride elevation. We generally only will use these agents in patients who really need them for a specific indication and aren't currently taking mycophenolate. Then we have niacin, which can exacerbate some side effects of our immunosuppressives, such as muscle-related events, insulin resistance, and hyperglycemia, GI intolerance, and hepatotoxicity. There is a limited role in ASCVD risk reduction, but we do consider it an add-on therapy for hypertriglyceridemia or statin-intolerant patients. I would say in our program, most of our patients who are on niacin are statin intolerant or have been on niacin for a long period of time. Then we have our omega-3 fatty acids or fish oils, with doses ranging from 2 to 10 grams daily, have demonstrated efficacy in controlling hypertriglyceridemia in kidney transplant recipients with minimal safety concerns. And there have been some purported non-lipid benefits in solid organ transplant, including hemodynamic improvement, increased kidney function, and maybe graft survival, which was shown in the animal models. Then we have Vascepa or icosapent ethyl. This is a highly purified form of EPA and is a newer agent. It had some novel and robust effects that was shown in the REDUCE-IT trial. It's recommended for patients with triglycerides greater than 500 milligrams per deciliter and those whose triglycerides remain above 150 milligrams per deciliter despite optimized LDL therapy and who need additional ASCVD risk reduction. There is a theoretical drug-drug interaction with cyclosporin and a possible increased bleeding risk, but generally safe to use. Then we have our PCSK9 inhibitors, evolocumab and alirocumab, which are monoclonal antibodies directed against PCSK9. These have been shown to lower plasma LDL-C levels by 50 to 70%. And have a 15% relative risk reduction for secondary ASCVD events and all-cause mortality in patients on statins. The recommended use is adjunctive therapy on a background of statins, with or without ezetimibe in patients with ASCVD, and there are no significant drug-drug interactions. There is some PCSK9 inhibitor data available in heart transplant. I tried to pull the most recently published, which was 7 heart transplant recipients from one institution, but then they combined with a cohort of 110 patients from literature review, so includes all of the prior trials that have been done. This is a single retrospective chart review from 2016 to 2021, combined with the previous data. So the single center cohort found a decrease in mean LDL from about 145 milligrams per deciliter to about 86. And this was found to be a statistically significant reduction. They didn't find a significant difference in average HDL, left ventricular ejection fraction, or coronary artery disease on left heart catheterization. And in the literature review, they found each of the 9 studies demonstrated an effective reduction of LDL ranging from 40% reduction to 87% with a mean of 55% from their baseline. The key takeaways from this are PCSK9 inhibitors are a safe, well-tolerated, and effective therapy for LDL reduction and should be considered in patients following orthotopic heart transplantation. Then we have our newer agent, bempedoic acid, with the brand name Nexletol. This is a prodrug that inhibits cytoplasmic ATP citrate lyase, or the ACL enzyme, in the liver and the kidney, which prevents the upregulation of the LDL receptor. This is a novel mechanism, so it can be used in combination with statins, with ezetimibe, and PCSK9 inhibitors, and is dosed 180 milligrams per day. There are no renal or hepatic dose adjustments or major DDIs, but you should avoid doses of simvastatin greater than 20 milligrams and pravastatin greater than 40 milligrams. And don't have efficacy data in transplant recipients, but here is the trial, phase 3 randomized clinical trial of patients with hypercholesterolemia. This was an analysis of about 3,600 patients from 4 different trials, and they were randomized 2-to-1 to bempedoic acid or placebo for 12 to 52 weeks. They found a mean baseline LDL level of about 107, and at week 12, the percent change was about 16% with bempedoic acid versus about 2% with placebo. And patients with a statin intolerance had about a 23% reduction versus placebo. And I just wanted to include this table because I really like to reference this in my own clinical practice of drug interactions between lipid-lowering agents and immunosuppressants, kind of a quick reference about which should be avoided and used with caution and possibly dose reduction. Moving back to pharmacist interventions, I wanted to talk quickly about medication coverage. One of my major roles is assisting with figuring out what agent we want to use, as well as what agent can we use through the patient's insurance. So with our PCSK9 inhibitors, Vascepa, bempedoic acid, those aren't covered by every insurance. Here we have a pharmacy prior authorization team who can be contacted via Epic InBasket, and we have test claim smart phrase that we can send, and if it's sent high priority, they'll get back to me within an hour. So when I'm working up patients ahead of clinic, I can send these test claims, or if we get an elevated fasting lipid panel, we can send them during clinic and figure out which agent we can use. I also assist with writing letters of medical necessity for insurance. This specifically applies mostly to PCSK9 inhibitors, and I have had to write one for Vascepa as well, explaining the clinical rationale for why a patient should be on one of these agents, as well as providing pharmacist counseling if they have questions on their specific new agents, how to administer a PCSK9 inhibitor since they are injectable, and providing that additional counseling. And then in terms of measuring outcomes, our program has been dealing with this question between our cardiologists of, is statin therapy for CAV prevention a class effect? As mentioned prior, the original Kabashagawa study in 1995 measured NK cell cytotoxicity, and then some studies with simvastatin measured coronary endothelial function and found that there was improvement and also decreased cytokine activation. So showing a little bit more with those statins versus others. It's generally accepted that this is a class effect with our newer agents, rosuvastatin and atorvastatin, especially in 1995 when those original studies were published. We didn't have atorvastatin or rosuvastatin. So the question remains, you know, is this the same for all statins? So we currently have a research study going on at UW to compare patients on pravastatin and simvastatin versus alternative statins, and we're looking at comparing the incidence of CAV development at 1 in 5 years post-transplant on coronary angiography and nuclear medicine stress tests. And secondary outcomes, we're looking at graft function, incidence of acute cellular rejection, mortality, hyperlipidemia, and drug toxicity. Just some closing thoughts on future directions. I think we do need some continued research of our newer anti-hyperlipidemic agents in the solid organ transplant population. I'm most interested in the study looking at PCSK9 inhibitors at possibly preventing CAV. I'm looking forward to seeing that data published. We'd like to expand our existing delegation protocol to include additional anti-hyperlipidemic agents for easier outpatient management, develop a multidisciplinary algorithm for hyperlipidemia management to assist our whole multidisciplinary team. And our center is going to be opening this high-risk hyperlipidemia clinic that we could refer patients to in the future to get them on some of those more experimental therapies such as inclisiran. And with that, I can take any questions at the end, but I will pass off the screen to the next presenter.
Hi everyone, my name is Yen, and today I'll be talking about hypertension management in kidney transplant patients, focusing on the impact of pharmacist intervention on cardiovascular health in the kidney transplant patient population. I just want to go over University of New Mexico Hospital. Here in our center, we are an academic tertiary care medical center and the only level 1 trauma center in New Mexico. For our transplant program, we only transplant kidneys at our center, and that started back in 1988. And in 2023, we completed 56 total kidney transplant. The unique thing about our center here is that we follow the patients for the lifetime of their kidney. And so in our clinics, we can see patients who are less than 5 years, but they can also be greater than 5 years out. And currently, I believe we follow more than 500 patients in our post-transplant clinics. Uniquely, with New Mexico, we do have what is called pharmacist clinicians who are considered advanced practice providers, and they're able to collaborate with physicians to provide certain primary or specialty care services with prescriptive authority that's independent of the supervising physician. We can also prescribe medications, perform physical exams, and order lab tests under our name. And so that is very helpful as far as, creating your own clinic. So how did the hypertension clinic come about? Well, it started as a telehealth clinic that was started in 2018 by Amanda Martinez, our previous transplant pharmacist, and it was mostly remote management of hypertension and referral based on the providers. Then when I came along in 2020 with the other transplant pharmacists, it's more of a mixed model clinic now where we do both remote and in-person management of hypertension. And so since the inception of the clinic, we have been able to retrospectively look back at the quality of care that we've provided in this clinic to see whether or not patients got anything from the clinic and how beneficial it was to control their blood pressure or help them manage their blood pressure. So this pharmacist-run blood pressure clinic, how it works is the patients with elevated blood pressure were identified by the transplant provider, and they would either send us a message in the EHR or put in the discharge note to be referred to us, and then have the coordinators schedule an appointment with us to go over blood pressure management. Patients that were enrolled were either called by the pharmacist and medications were adjusted based on an algorithm approved by the supervising physician. And that was prior to the transplant pharmacists becoming pharmacist clinicians. And then for patients who were enrolled, once they achieved blood pressure control and had an average blood pressure of less than 130/80, they were then discharged back to regular clinic. Now, most patients will be discharged and they won't have to be re-enrolled, but there are some patients who get re-referred if their clinical status changes at any point in time. So from this clinic, we did a quality improvement project where we looked at, the care that we gave patients. And so we retrospectively did a chart review on 56 adult post-kidney transplant patients at our center who were managed by clinical pharmacists from 2018 to 2021. Blood pressure reading pre and post enrollment were collected and reviewed, as well as demographic data, cause of end-stage renal disease. We also had a survey component that was used to assess patient satisfaction, understanding of blood pressure management, as well as quality of care that was received. So this is the post-transplant hypertension management algorithm that we came up with at our center. And as you can see, anyone with blood pressure above the goal were enrolled in our clinic based on the provider. We definitely start with, lifestyle changes if possible. And then at subsequent visits, and then you can see the drug therapy that we are able to prescribe, and then modification of current regimen or discontinuation of medications. And so we followed this algorithm with each of our patients to help them with their blood pressure management. For the quality improvement project, overall, there was 56 patients who had a mean age of 60, and most of them identified as Hispanic and white. Majority of the patients were male, and then the main cause of end-stage renal disease was diabetes. Our center had most patients on mycophenolate or tacrolimus. And then because our center is steroid sparing, we did have a small percentage though that were on prednisone lifelong. The blood pressure that we utilized at the referral was mostly the clinic blood pressure, although there was a mix of both self-monitoring and or clinic blood pressure. The blood pressure at referral was 148/79 with a heart rate averaging at 77. And so the patients that were enrolled by 6 months, 92.4% of the patient met defined blood pressure goals and were no longer being followed. However, there was 7.6% of the patients who did not meet goal and were still being followed at the end of the study. As far as the survey results, 96% rated their quality of care that they received as good or excellent, and then 96.9% felt the clinic was valuable in improving their blood pressure. And this was asked at the end of their discharge from the clinic. So overall, from our clinic, we found that a multidisciplinary approach to managing post-transplant hypertension may lead to improved quality of care as well as better outcomes. And then patients who had multidisciplinary approach to care were more knowledgeable about their blood pressure goals and how to manage their blood pressure at home. There are definitely challenges to this clinic, one of them being loss to follow-up. And so while we get referrals for patients, sometimes it's difficult for us to follow up with them either via phone or having them come into clinic, because New Mexico is pretty rural. And so a lot of patients, it may take them a while to get into clinic and they don't have service at home. So those patients, we are not able to make an impact until the next follow-up in clinic. There are other patients that we have a lot of frequent follow-ups, and it's really just me and 2 other transplant pharmacists. And so sometimes we're not able to follow up as quickly as we would like to. And then definitely the re-referrals for patients too that can add back onto our patient load. Other things logistically, really clinic space, if we're able to, this clinic was started in 2018. And then when I came on, it was during COVID. So we did a lot of telehealth. But for those patients that have to come in due to one reason or another, it is difficult if there is a lack of clinic space. with that, we will open it up to any questions that you guys might have.
Quick reminder for folks to type any questions that you have for our speakers today into the chat, but I'll kick it off by asking Ian a question. What is the usual turnaround time from receiving a referral for the clinic to when a pharmacist connects with the patient?
So for our clinic, typically it's within a couple of weeks. So let's say the provider starts a new medication and they tell us that they want us to follow up, then we'll typically call them within 2 to 4 weeks, depending on like how fast they'll be able to start that new medication. And we definitely want to make sure that they have time to take the medication, make sure they're checking their blood pressure. The coordinators are pretty good about putting them in my clinic within the month. And then depending on, how often that we need to talk to them, I'll either schedule them another monthly follow-up visit, if not sooner.
Are there any questions from the audience? I know we are at time, so I will thank everyone for joining us today. A big thank you, of course, to the speakers for sharing their wealth of knowledge with us and all their preparations for today's webinar. And a quick reminder that at the end, later today, you will be receiving information about how to obtain seat credit. Thanks so much.